Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everybody for the new session of the Cornea series with our Professor Tariq Katamish. I would like to welcome you all, and we are delighted to listen to him. And of course, many thanks to Dr. Barak Qubaisi, who is going to moderate the session. Dr. Tariq is a well-known and renowned international figure in keratoplasty, and no need to be introduced. So the stage is yours, Dr. Tariq.
Bismillah ar-Rahman ar-Rahim. Many thanks to my dear friend, Dr. Mazen Sinjab, the founder of the Sinjab Academy. I am always honored to be in this highly prestigious platform. And meanwhile, I also welcome my dear friend, Dr. Barak Al-Qubaisi, for moderating this session and for his always valuable remarks after the lecture. I will discuss today a very important aspect of DMEK technique, which is very important and in the same time the most difficult part of the DMEK operation, the DMEK unfolding and orientation techniques. So this is a very important part of DMEK surgery. And in my last DMEK lecture, it was introduction to DMEK. I have went through these techniques, but I will do in this lecture more concentration in these two topics. So I will share my screen now. I want to just is it clear now, Dr. Mazen?
Yes. Yes, it is.
Okay. Okay, I'm just making yes. So I will speak today about the DMEK roll orientation and unfolding techniques. The DMEK technique, which I have mentioned in my last lecture, have 7 steps: donor tissue preparation, graft loading in the DMEK injectors, patient or recipient preparation, and injection of the DMEK roll in the anterior chamber. And folding the DMEK graft, we have to make proper orientation before unfolding, and then we'll do the unfolding and centration techniques. And lastly, we make the graft tamponade with air or SF6. So my talk today will be concentrated on the DMEK graft orientation and the DMEK graft unfolding and centration techniques. I will give a very brief introduction to the steps before orientation of the DMEK graft in the anterior chamber. So first of all, we do DMEK tissue preparation. I either use the classic technique on the left-hand side, in which we make a peripheral incisions, and then we start stripping from the periphery. This technique may have the disadvantage of occurrence of some peripheral tear. On the right-hand side of the screen, I'm using another recent technique, which is the liquid bubble technique, in which the idea is to create a pocket, sub-desmet membrane pocket, and then to inject a Trepan blue. This Trepan blue under pressure will make a pressure wave, which will, as you see, make stripping of desmet membrane immediately from limbus to limbus, and the incidence of occurrence of peripheral tears are very limited. So whatever technique you use, whether you use this classic technique or you use the liquid bubble technique, you will be having at the end of your technique this beautiful graft, as you see. We have different types of DMEK rolls. We have the wide DMEK roll. You see the DMEK roll is very wide, And this is a very good type of DMEK roll. This makes an indication that this roll will unfold easily during the unfolding techniques. Another type of DMEK roll is the double scroll technique. This double scroll technique is also a very nice technique, and it unfolds easily in the anterior chamber. Another type of DMEK roll is the triangular roll, as you see. And sometimes with old age donor, you may find that the DMEK graft is as if it is a disc. It doesn't want to fold, but by pushing some BSS toward the graft, you will be having the roll will be fine. The worst types of DMEK roll is the tight DMEK roll. As you see, these are very tight DMEK rolls, usually due to young age of the donor. So I always advise the beginners of doing DMEK, you should start with the donor age not less than 60 years ago. This type of DMEK rolls or these different types depend upon the amount of elastic content of this membrane. So this behavior depend upon the amount of elastic tissue in this membrane. So I will speak, of course, about unfolding techniques, but you can easily imagine which type of this will unfold easily. Is it the tight DMEK roll or the wide? The answer is very, very, very obvious. It is very easy to unfold a wide roll, but it's very difficult to unfold a tight roll. The same principle, if you compare the tight roll with the double scroll, it will be obvious again that the tight scroll, you will have some difficulty in unfolding, but with the double scroll, you will have easy unfolding. So after you have prepared your DMEK graft, you want to transfer this DMEK graft to the patient's eye. So you want to have a carrier. This carrier, we call it the DMEK injectors. You either use an intraocular lens cartridge, or you may use the non-touch technique for loading the DMEK graft. And then you come to the patient. You have to prepare your patient. The preparation of the patient is as important as other steps. You should do peeling epithelium for proper visualization. You should make a proper wound construction, making into consideration that the dermatorexis should be larger than the MIG graft size. You should make the dermatorexis either under air or under cohesive viscoelastic. This step is very important because if you have to leave the stroma smooth, and if you leave remnants of this membrane in the center of the stroma, this may affect the quality of vision. And if you leave some remnants of this membrane at the periphery, this may be a source of recurrence and graft displacement. And you should do also an inferior iridectomy by vitreous cutter to guard against papillary block, because I always leave the eye with large amount of gas or air. So you have now having your DMEK graft in your injector, and you prepare the patient. Now you will inject the DMEK graft in the anterior chamber. If you are using the intraocular lens cartridge, you should use anterior chamber maintainer, because there is little amount of fluid in the cartridge. But on the other hand, if you are using the glass pipette, which is more common, no need to have an anterior chamber maintainer, because the glass pipette has a lot of fluid. So again, the DMEK technique: donor tissue preparation, DMEK injectors, recipient preparation, injection of DMEK in the anterior chamber, and then we will come to the title of our lecture today is DMEK graft orientation and DMEK graft unfolding and centration. So the first part of my lecture is how to identify the proper orientation of DMEK graft, because as you know, if you have your DMEK graft upside down, this means primary graft failure. No way. It is unacceptable at all to put the graft upside down. You will be having primary graft failure from day one. So this is a very important item. You should be sure that the graft is in its proper orientation before unfolding it. So what is the natural behavior of any DMEK graft? Fortunately enough, all DMEK grafts all over the world, all over the nations, all over wherever you have a DMEK graft, the behavior is the same. You usually have the endothelium outside and the descent membrane inside in 100% of the cases. So this is a very good and we are lucky to have same behavior of each DMEK graft to know our orientation. So this is the proper orientation of the DMEK graft in the anterior chamber. You should have your DMEK graft like this, the endothelium facing toward the iris, and the tissue scrolls, these tissue scrolls should be facing toward the stroma. This is the correct orientation. If you have the reverse, the endothelium is facing to the stroma, you will be having an upside down graft. So if you have your scroll like this, and you start unfolding it and injection of air, you will be having the DMEK graft in a proper orientation. But if you have this orientation and you start unfolding it, you will be unfolding it in upside down configuration. So as I always say, that if you want to have a successful DMEK, you have to have a triad of three things: proper orientation, smooth unfolding without too many trauma, and perfect centration. These are the triad for the success of any DMEK operation. So how to avoid upside down graft? Or in another way, how to know the proper orientation of your DMEK graft inside the anterior chamber? We have too many ways to do this. We can do this while the graft is still in the intraocular lens cartilage or in the glass pipette. And we can do other signs after injection of the DMEK graft in the anterior chamber. The most important sign is Mutsoris sign or the blue cannula sign. Or we may use what we call it the tangential endo-illumination. And during the unfolding of the DMEK graft, if you are lucky and having intraoperative anterior segment OCT, it will be a very valuable tool to monitor the unfolding process and to know the orientation. And at the end of the operation, after fixing the DMEK graft by air bubble or gas to the stroma, the well-known S-stromal stamp is a very valuable sign for proper orientation. So this is how to judge the orientation of the DMEK graft before injection in the eye. You see, you can manipulate the DMEK graft by a very small cannula to have this triangle. You see, this triangle, it should face you, not facing to the other side. You see this triangle. So if you succeed to inject the DMEK graft and to keep this triangle facing toward you during the operation, this is a good sign that you are doing the job in the proper orientation. So you have to look always to this triangle, and you should be able to keep it looking to you until you inject it in the anterior chamber. This is the first sign of how to avoid upside down graft. The second very important sign is what we call it Mutsoris sign. The idea of this sign is very clever and very simple. If you have your graft inside the anterior chamber, and if you put your spatula or cannula over the graft, I stress again, you should put the spatula over the graft and make sideway movement. You will, if you see that your cannula is hidden under a scroll, this means that the scrolls are in the proper orientation. But if you have your graft inside the eye and you put the cannula above the graft, as I have mentioned, and you make sideway movement, you will not be able to go under the scroll, because the scroll is toward the iris in a wrong direction. So this very simple and basic sign is very valuable to guard against, to detect the orientation before unfolding. It's not allowed to start unfolding before you are sure that the graft in the proper orientation. So this is the idea of the Montessori sign. You put your spatula inside the DMEK roll since it is hidden. So this means that the fold is facing to you. This means that is a proper orientation. And sometimes you call it the blue cannula sign. So this example, you see, putting the spatula, it is hidden under this fold. So this fold is facing to the stroma. So the graft here is 100% in the proper orientation. Another Montessori sign, you look to this, you cannot judge. Someone may tell me, it is very clear that these folds are looking to me or looking to the iris. No, it will not be so clear in the operation. Sometimes you may have some hazy cornea, and sometimes because the graft is very fragile, you cannot judge whether the rolls are facing to you or to the other side. So you just put a cannula, as you see now, put it over the graft, you see, put it over the graft, and make side movement. You see, the cannula is hidden now under the fold. So you are sure now that you are in a proper orientation. This is a very simple but a very delicate test. Another example of Montessori sign, you see this fold, is it facing to me or facing toward the iris? I will pass the spatula above the DMEK graft and I will see now. You will see with me, you see, it is hidden under the fold. So this means that the graft is in the proper orientation as I have mentioned. This is a first time to talk about this. You may use a small bubble as a test for Montessori sign, not necessarily the spatula. So if you inject a very small bubble inside the roll, you see, you will find now that you see now this fold is covering the air bubble. So this means that the graft in the proper orientation. So you have used the air bubble as if it is a spatula, and then you can now 100% sure that since this fold is covering the air bubble, so this is in the proper orientation. If you inject air and you find the whole air bubble is covered by DMEK tissue, this means that the graft is inverted. This is the example of the tangential end illumination. You close up your microscope lights and you use the fiber optic illumination at the limbus. You can have some more observation, but to be honest with you, I don't use this technique of end illumination except in extreme cases with very hazy media. But for the most cases, I don't use this technique. If you have anterior segment OCT, this is an example from the YouTube. It is not my video. You see, you are during your technique, you see now that the graft is in the wrong orientation because the scroll is facing toward the iris. So you will stop and you will flip your graft and you will watch again. So it is a live orientation, you see, after unfolding, after flipping the graft, and you will check again, you will be having the scroll facing to the stroma. So this is a very valuable and will give you a real-time orientation of the DMEK. This is a video of one of my cases. Again, you see, the orientation now is wrong. The graft is looking behind. And now after flipping, the graft is looking, or the scrolls are looking upwards. So it's very important if you, but of course, as you know, the anterior segment OCT in the operating room is very expensive and not available in any hospital. So we'll come now to the well-known and the famous stromal stamp or S stamp. The idea of the S stamp is when you are stamping S, and if you flip it on the other direction, it will not be S. Is 2. And if you use letter L and flip it, it will not be L. And if you use F, it will not be F. So these some letters, if you flip it, it will give you another shape. So this is the idea of the S stamp or F stamp. So this is how we do the S stamp or the F stamp. During preparation, we have the DMEK tissue to the side, as you see. And then we make proper drying, And then I will use now 3 mm skin biopsy punch to make a stromal window. You see, I make a stromal window on the stroma. Of course, I have my descent membrane at one side. And then when I have my stromal window, I push back again the descent membrane by wetting it. And by some drying technique, I will have the descent membrane again. And then I flip the graft and open this stromal window from the other side. It usually has a small hinge. And I make perfect dryness. And if you don't have an S stamp, you can draw your S by gentian violet dye using a Stensky hook, as you see. But of course, if you have an S mark, it will be much easier. So this is the S stamp. If you have an S mark, as you see, you just make the S stamp. Very easy and very simple. The F stamp, this is example of the F stamp after making the stromal window. You open your stromal window and you make perfect, you have to make perfect dryness of the descent membrane to have a very well-defined stamp, not a diffuse one. And you use the F stamp as you see. Another example of the F stamp, you make dryness and make your F. At the end of the operation, you should see this F, you see? But if you see it like this, if you flip the graph now, if you see it like this is not F now. So if you see at the end of operation, the letter F is inverted, this means that the graph is inverted. So these letters, whether either S or F, are very valuable in the orientation of the DMEK graph. So this example of a case, you see, is it S or 2? You see, I think it is quite clear that it is 2, not S. So this means that the graph is inverted. So you have to flip this graph. I will speak now about how to flip the graph. You flip the graph and you unfold again. And at the end of the operation, you make another check of the letter S. As you will see now, it is clear that this letter S and not letter 2. This example of inverted graph in which I use the two signs, the S and the Montessori signs. You see this unfolding of the graph. I want to mention here that easy unfolding doesn't mean it is in the proper orientation. Be careful of this important information. Easy unfolding doesn't mean that it is in the proper orientation. After proper unfolding, you see, I will find now that it is letter 2, not S. I was sure that it is in the proper orientation, but thanks for this letter S, it is 2 now. So I have to float this again and to flip it again. And before unfolding again, I want to be sure by Montessori sign. So I will do now the Montessori sign before unfold. You see, the Montessori sign now is positive, you see? So I am sure now that it is in the proper orientation. So I will start unfolding with confidence. And at the end of the operation, I will find that it is letter S, not letter 2, as you will see now. You see now? Now it is the letter S, quite clear here. So sometimes you may use the two signs. For myself, I usually do DALK with DMEK. Since I am making with DALK, I can't make the stromal window. So if I have two cases, DALK and DMEK, I depend totally on the Montessori sign. But if I have a case of DMEK only, I can make a stromal window. I depend on the S mark. If you have the graft inverted and you want to flip it to have the proper orientation, just inject a short burst of BSS along the iris plane to have this flipping action, as you see. Very short burst toward the iris plane. But be careful, if you just inject VSS toward the graft itself, it will push it to the angle of the anterior chamber and it will not flip it. So the S-stromal stamp is the most sure sign of correct graft orientation. This is advantage. The disadvantage, as I have mentioned, it sacrifices the cornea and we cannot use it for that. So I will come now to the second part of my presentation, is the DMEK roll unfolding. So you have now proper orientation. You are sure that the graft is orientation. You will start now unfolding. We have too many techniques. One of the most simple technique is the tapping technique. Just simple tapping over the cornea. This will create a fluid wave. This fluid wave will indirectly unfold the DMEK graft, as you see, but it is not always easy as you see in this example. This is a simple tapping technique. Sometimes you may use tapping and fixing, what we call the Dressmer technique, or the pinch and unfold. You pinch the graft here, and then you start unfolding of this fold. You see, you pinch the graft down and start unfolding the graft by the other spatula. This is, we call it the pinch and unroll technique, or the Dressmer technique. Of course, in any technique of the DMEK graft unfolding, shallowing of the anterior chamber is very important. You have to work in a very shallow chamber, but not lost the anterior chamber. The third technique, which I prefer, is the bubble in the roll technique, in which you inject a small bubble in the roll and you manipulate this bubble as if it is a third hand in the anterior chamber to unfold the DMEK graft. As you see, with some patients, with some shallowing of the anterior chamber, with some manipulations, you will be able to unfold this graft. Some very tight DMEK rolls, you may use repeated fluid injection. You see in this example, repeated fluid injection may open a DMEK graft, as you see. You see this tight scroll. If you inject the fluid in a certain direction, you will be able to open this DMEK graft. Sometimes you may use the spatula, but from the desmoid membrane side for, as you see, folding, or most probably you may use it for centration. You may use the spatula for centering your graft or opening of some folds. So change your tactics along the way. Use all your weapons you got with whatever switch. And sometimes you may use two techniques in the same case. So the criteria for success in unfolding, you should have the following. You should have proper visualization. You have to see your DMEK graft, how it behaves. So how to make proper visualization? By epithelial peeling and by proper staining of DMEK graft for 2 to 3 minutes. I want to emphasize that the S mark is not for visualization, it is for orientation. To see your DMEK graft, you should stain it probably for at least 2 minutes. A second important point, that you should make the proper sizing of the DMEK graft. If you are using a large DMEK graft in a small eye, it will be very difficult to unfold in this very tight space. So the proper matching of the DMEK graft size to the patient's eye is very important. As I have mentioned, choose all donor. As you see, all donor grafts are wide and can unfold easily. If you are following these advices, proper visualization, proper adjustment of the size, choosing donor age above 60 years, you will be able to success in unfolding the DMEK graft, and you should also have some patience in dealing with this DMEK rolls, especially in your first few beginning cases. So I will show now some of the techniques magnified. This is the tapping technique, as you see. The idea is you press over the cornea to create a fluid wave. This fluid wave will open the two scrolls, and just tapping, as you see, we are not using direct trauma to the graft. We are using indirect forces, tapping over the cornea. this will make a fluid wave which will open. Another example of tapping technique, you see, just tapping in the long axis of the DMEK graft. You should tap in the long axis. You will find that the DMEK roll will start open now. And as I have mentioned, you have to make some shallowing. You see, it start open. Now make shallowing, and using single cannula, but you can manipulate it and to have your DMEK graft completely open, as you see from this example. You see, this is a simple tapping technique. You have the graft now open all through, and you have the proper centration and proper orientation. The second technique, the idea is the Drismer technique. You pinch the graft here, you fix it, and you start unfolding this fold. So you see, this is a graft, and you will pinch at one, you have this fold resisting unfolding. So you pinch this side and make unfolding tapping technique from the other side. Of course, with some shallowing, you will be having your graft unfolded. Another example of the Drismer technique, you see, you are trying single cannula, but you have one of the folds which is resistant to unfold. So pinch the other one, the other side down, as you see, pinch it from above, yes, and then start shallowing of the anterior chamber and making the tapping technique. So this is I call it the pinch and unroll technique, or the Drismer technique. Repeated fluid injection, the idea is to inject the fluid at this edge, not any injection of fluid. You try to direct your fluid wave to this edge. This will help open a tight DMEK roll. You see from this case, you see now, you see just injection of fluid, the graft opens. So you have to be familiar with all these techniques and to use it in the proper situation. Another example for the repeated fluid injection technique, you see this very tight roll. You will think it will never unfold, but with some patients, some injection of fluid, as you see, and directing fluid to certain direction, you will be astonished that you will be having the DMEK graft open now. You see, it will open now. You see, I'm trying to inject to open a special edge, as you see, and you will find now, this of course is for the difficult cases. You see now, start open. Since you have this opening, you can continue with the other techniques you have, either the tapping technique or the Drismer technique. Sometimes, as I have told you, I am using spatula. Look to this case, you see, I want to center the DMEK graft. I'm using my spatula, you see, to displace the DMEK graft gently over the iris. But in this maneuver, you should do this from this membrane side. It is not allowed to touch the endothelium. So this is very helpful, especially for centration. You may use the spatula, as you see, for proper centration, very gentle movement, and sweep it over the iris. Another example for using the spatula for centration, and you may use it also for fixation. You see, you by your spatula, you displace your graft down, you see, and if you want to unfold the other fold, it moves up again. So you can go by your spatula and drag it down again and use it for fixation. You see, use it for fixation and use the other cannula for unfolding. So you have a lot of maneuvers, and depending upon the situation you have. So you have to be able to master all these techniques for proper smooth unfolding. The commonest technique I usually use is the bubble in the roll technique. I will be having my DMEK roll parallel in the same axis of one of the prostheses, and using a 1 cc syringe, I inject a very small bubble, as you see here, a very small bubble in the anterior chamber to open the DMEK graft, as you see. And with gentle manipulation of the bubble, I can open the DMEK. Another example, you see, I am injecting a very small bubble in the anterior chamber, inside the roll, you see, and then reform the anterior chamber, and then start manipulating your DMEK graft by moving this bubble up, down, nasal, temporal. You will find that the DMEK graft is completely unfolded. And another technique also here, you may inject small bubble. It may come in too many bubbles, too many small bubbles, as you see in this example. Too many bubbles. You can use these small bubbles for the DMEK graft unfolding. You see, I am trying to manipulate this bubble for unfolding, and with some patience and with some shallowing of the anterior chamber, you will be able to completely unfold your DMEK graft without touching it, just by indirect forces from tapping the cornea. If you notice, all of the techniques mentioned before rely on external forces or bubbles to manipulate the tissue into the correct position and conformation. So some rules to be kept in mind during unfolding. The anterior chamber should be shallow, but not flat. A shallow anterior chamber allows the iris act as a third finger to keep the graft from rolling back up on itself. Use short jets of fluid and tapping on the corneal surface to open the graft. It is best to maintain gross centration of the graft while unfolding. Don't unfold the graft while it is in the angle of the anterior chamber. Try to make a proper centration, and then to avoid, start unfolding to avoid losing the graft into the angle. And in addition to centration, orientation, of course, is very important. Positioning the graft. You can't push a DMEK graft where you want to go. It is not like a DMEK graft. You have to lead it. You have to use physics. This requires thinking about the physics of fluid and pressure as you work with this tissue. DMEK roll unfolding techniques, though, is difficult and is taken against DMEK, being a disadvantage in learning the operation, but can be simplified by the previous techniques. So they always say the DMEK is very difficult. Yes, it is difficult, but it could be simplified by using certain simple techniques. So why you are insisting on trying to transfer our knowledge of this operation to the young generation? Why? It's difficult operation, tough learning curve, because the outcome is marvelous. These are some of the outcome. You see the immediate post-operative dehydration of the cornea, the compact cornea, and the clear cornea. You see this second post-operative day, the cornea is crystal clear, and the patient can move around. Here also, there's no suture. It is sutureless operation with crystal clear cornea. Very short recovery time. You can achieve six vision. Very short. You see this, how beautiful the DMEK is. So as I always say, you have to choose between the easy penetrating keratoplasty with a lot of complication and long-term recovery, and between the challenging DMEK with its marvelous outcome. These are my some of the social media platforms, my email, the Facebook account, YouTube channel, WhatsApp number. If anyone needs any support or any help during his transition to DMEK, I will be happy to have this support. And I would like to thank you all for your kind and listening, and I am ready for any questions. Thank you.
Thank you very much, Dr. Tariq, for the great presentation. And I would like to open the discussion. Dr. Bara. Dr. Bara, unmute yourself, please. Dr. Bara.
He's still unmuted.
Maybe the net is...
Thank you, Dr. Tariq, for this.
Yeah, there might be something in the connection. So meanwhile, let's see if the audience have any Questions?
Surprise, yes.
Yeah, Dr. Barak,
Can you
please.
hear me, Doctor? Dr.
Yes.
Mazen, can you hear me?
Yes.
Yeah. Thank you,
Yes.
Dr. Tariq, for this wonderful lecture as usual. Very, very surgeon, like giving us and nailing every concept of unfold. And we'd like to thank also Dr. Tariq. Dr. Tariq, is there any way that we can use viscoelastic in orienting or trying to unfolding, sorry, the graft?
No, actually the viscoelastic is completely prohibited in any DMEK technique. Since if you are using viscoelastic, you will not be able to unfold the graft and you will be having the viscoelastic adhere to the stroma. And as I have mentioned before, even you are using viscoelastic, for example, dysmetrixes, you have to use the cohesive viscoelastic and you have to make thorough, very thorough washing because if you will be having any remnants of viscoelastic in the anterior chamber, this will be jeopardize the mechanics of unfolding the graft. So it's not allowed at all to use a viscoelastic in unfolding techniques.
So we'll go to the participants' questions. The ideal size of the DMEK graft.
This is a very good question. There is no ideal size. It is the ideal size is the size should fit the patient eye. So the range is from 7 to 8.5. But for myself, I usually make a tip. I project the slit lamp beam over the patient's cornea. And I start lengthening and shortening the slit lamp beam over the cornea as if this is a future DMEK graft. And I usually leave, for example, 1.5 millimeter or 1 millimeter from the limbus from each side. And this will be the proper graft size. But if you want to say what is the commonest graft size, the commonest is 8. But this is not the appropriate for each patient. So if you have a small eye, you may use a small graft as 7 millimeter. And if you have a large eye, you may have a graft as 8.5 millimeter. For myself, I am usually moving from 7 to 8. Sometimes 7, sometimes 7.25, 7.5, 7.75, or 8. This is my usual sizes, but it should be matching the patient's anterior chamber anatomy.
And the scoring and the stripping, you make it smaller, larger. What do you prefer?
No, I don't understand the question, Dr. Bara.
When you strip the disseminate membrane from the
Yes.
host eye, yeah, so you make it the same size, smaller, larger.
We usually make it larger. The smatorexis should be larger than the DMEK graft size because we need to have our DMEK graft on peristroma. Because if you have a large graft and a small dysmatorexis, you may have overlap of the DMEK graft over the remnant membrane. This overlap is not acceptable because this may be a source of leakage of BSS of aqueous under the DMEK graft edge and may be a source of recurrence. So we usually have about 0.5 millimeter difference in size between the DMEK graft size and the symmetric size. And this area of peristroma, no problem, because as you know, there is sliding of the DMEK endothelial cells over this area. Sometimes some may ask, what if you leave a rim with peristroma with no endothelium? No, the new endothelium will slide and cover this defect.
Yeah, the reason I'm asking this question because I saw a new technique of one of the Indian guys who does the stripping smaller, and then whenever he unfolds the graft, he do tucking underneath the host stripping area. So it's like gluing the graft inside the decimate membrane of the host patient.
This is not the classic way
Yeah.
of doing the job. It's very complicated and it's very difficult to tuck the DMEK graft, and it's not as easy as described. But I think
Yes.
the majority of surgeons agree on having
Should be larger.
this matrix is larger than the DMEK graft size.
Someone is asking, is there any difference or advantage in using gas over air?
The only advantage, on my opinion, is the longer tamponade, because if you have long tamponade for more 2 days, this will make the incidence of rebubbling less. So if you are using gas, I think the rebubbling rate will be slightly better than if you are using air. But for myself, I think that rebubbling rate do not depend on whether you're using gas or air only. It depends upon your technique, the perfect dysmatorexis, the proper centration, and having a full globe with air or gas for the first 20 minutes. These are the most important things for as regard the rebubbling rate. But if you are using gas or air, doesn't make a big difference, but theoretical point of view, it will be having more chances of lowering the incidence of rebubbling.
Mhm.
And if you are using gas, you should use the non-expansile concentration of SFS6, which is 20% concentration. You take 1 cc of gas and you make another 4 cc of air. You should use the non-expansile concentration, not allowed to use the pure SFS6 gas.
Someone is asking, have you experienced SAD cannula from goiter for unfolding?
Yes, this is sometimes you have different types of cannulas with side pores. You inject, you put your cannula inside the DMEK roll, and then the fluid comes from sides and it will open your graft. I have used it few times, but I didn't find it very valuable. But I think why not? It may work in other hands than me, but it doesn't work with me very good. But it may work with other surgeons in different way. But the idea is very smart idea. Injecting saline inside the roll, it will open the roll from two sides.
Someone is asking, when you use a small bubble to unfold, what do you do at the end? You just inject air, so the bubble is
No.
gone?
Yes, I'm using the small bubble for unfolding the graft to have it completely unfolded. And before injecting air, I have to suck this small bubble. I go inside above the graft and to suck this small bubble, and then go by another cannula, by another syringe, and to inject air under the graft to have it for the final tamponade. So I may not show the last step of sucking this bubble, but I should suck it before injecting the other bubble, because this bubble, small bubble, is above the graft, and the final tamponade, we need the bubble below the graft.
Yeah. Some questions are answered during the course of the lecture. So someone is asking if you have a small graft tear at the periphery, can you reduce the graft?
Yes, the management of graft tears, if you have a small graft tear in the periphery, you can make it rounded edge. And if it doesn't jeopardize the mechanics of unfolding, you can use it. I have a lot of grafts with missing parts in the periphery because I have very small tears, and it works very good. But if you have multiple tears and large tears, will find a difficulty in unfolding these distorted grafts. But this depends upon your experience. Some experienced surgeons may work with a graft with a large tear, others will not be able. So the general rule is you convert this small tear into a rounded tear, and at the end of the day, you will be having a graft missing some of its endothelial cell count, no more than that.
Is it a must to do peripheral iridectomy?
We have two techniques of using air or gas. The technique I am using is to inject a full air bubble, almost 90% of the anterior chamber. Since and I leave the patient with this large amount of air. So since I am leaving the patient with a large amount of air, I have to make an inferior iridectomy, whether before the operation by YAG laser, 1 week before the operation, or intraoperative by using the vitreous cutter. But there is another school of not to do a peripheral iridectomy. They are doing complete air fill. They make the pressure up to 40 millimeter mercury, and they leave the patient for 40 minutes outside the operating room and getting him back again after 30 to 40 minutes, and they make the bubble about 50% of its size. So they are depending on the first 40 minutes for doing the job. For my technique, I am depending on few days. So I am leaving the patient with a large bubble. So if you are using a very large bubble, you should use inferior PI. But if you are using a large bubble for 30 minutes, you can, and you decrease the size, you can without.
How long should the patient be in the supine position after surgery?
As long there is a reasonable size of bubble. For example, not less than 2, 3, 4 days maximum. Sometimes I'm injecting the patient with a large bubble, and I astonish that second day they come with a very small bubble. So there is no need to still supine position. And sometimes if I injecting gas, I find a sizable bubble which may last for 3 to 4 days. So since I have this bubble, I advise the patient to stay supine. Of course, it's not supine for the whole day. We advise him to be 70% or 80% of his time supine. So the supine position depends upon the size of the air. If it is still have the surface tension to support the membrane, we continue supine position. If it is very small, we no need for supine position anymore.
Mhm. Someone is asking that you recommended a graft from an old age patient, but as you know, old age have small endothelial cell count. So is that affecting the result of the DMEK surgery?
Oh, no, I disagree on this information. We have a lot of old age graft with remarkable endothelial cell count. As you know, in the DMEK surgery, we lose endothelial cell during the unfolding techniques. So the least endothelial cell count permissible for the DMEK is about 2,500. So it is very easy to find a lot of old donor aged grafts with this amount of endothelial cells. And of course, more experience, you can go with the age down. For example, I have started doing DMEK about 10 years ago. I was insisting of doing DMEK with the grafts even above 70 years. And after working and making more confidence, I started to make it above 60 years. And now I may accept the grafts above 50 years. So this depends upon the experience of the surgeon. But for the beginner, a great advice from me, don't use any graft except above 60 or even 65 years old.
Someone is asking about your opinion in cutting an asymmetric edge of the graft for orientation.
Yes, there's a lot of asymmetric edge of the graft, but for myself, I didn't try it. I feel that it's uncontrollable way of cutting the edge, and I didn't try it because I have a very simple ways to make the same job. As the Mitsoris sign is a very important sign, and very simple sign, and very easy. And if I have the chance to do the S mark, so I know that some surgeons are advising using this orientation marks cutting the graft in a asymmetrical way. But for myself, I don't use this asymmetrical cutting.
Mhm. So a great question from one of the attendees. Can you please talk a little bit about DMEK in a failed penetrating keratoplasty graft?
Yes, the DMEK, one of the great indications for doing DMEK, of course, we know the main indications for doing DMEK is Fuchs endothelial dystrophy and the pseudophakic bullous keratopathy. There are two other indications that are very important. One in the young age, the Chet syndrome, the congenital hereditary dystrophy, and after failed PK. As you know, if you have a failed PK, you will be having a chance of another failure if you are doing another PK, because as you know, the rejection rate of PK is much higher for the second time than the first time. So it is very, very, very valuable to use the DMEK after PK. So the tips in this regard is you have to choose a proper size of your DMEK graft according to your previous graft. And we have two schools here. You either do dysmatorexis inside the previous scar of the old PKB, but you have to be very careful because you may use Sinjab hook. You may open the old wound. So you have to be very careful in doing dysmatorexis inside the scar of the previous graft, and you have to choose the proper sizing of the DMEK graft to be inside the scar and to have a proper centration, not to override the edge of the previous graft, which may be a source of recurrence. This one point of view. The other point of view is some surgeons say, no, the endothelium here is not diseased endothelium, it's just rejected. So you can put your graft directly over the endothelium without dysmatorexis. So for myself, I don't believe in this putting the DMEK endothelium over endothelium, but some surgeons are advising doing that. But for myself, I do this very careful dysmatorexis and put my new graft on Beristrom. This is my only comments on this issue. And if you the main advantage in this operation is that the rejection rate of DMEK is 25 times less than PKB, especially if you are doing a PKB after graft rejection. So I highly recommend any surgeon who has graft rejection to do DMEK, not to do another penetrating cataplasty.
Someone is asking for how long after this kind of surgery do you use steroids?
The regime of using steroids, I usually use prednisolone acetate, Breadfort or Econobred or OptiBred, whatever the name in your country, prednisolone acetate, 1%. I usually use it for 5 times per day for 1 month. Then gradual withdrawal, 4 times per day another month, 3 times per day another month, twice per day another month, and once per day another month. I use prednisolone 5 months. And then after stopping prednisolone, I have to use fluoromethylone, like for example, Flucon or FML. This fluoromethylone is a very small dose, twice daily. It should be used for years, because in spite of the fact that the rejection rate of DMEK is very little, but it is present. So this very small amount of fluoromethylone will guard against rejection of the DMEK graft. Keeping in mind that if you are using prednisolone acetate in the first 5 months and you have any problem with the intraocular pressure, for example, if you have a patient which is responder to IOP elevation to steroids, it is very forgiving in the DMEK graft that you may stop prednisolone very early in your operation and shift to dexamethasone because very forgiving. That you may, this is another advantage of DMEK, that it doesn't need steroids as penetrative cardioplasty. And you have, if you have any steroid responder, you can shift to a weaker steroid and with very good results.
In the case of shed, do you prefer ultra-thin DZEK or DMEK because of the high elasticity of the host dissemin?
Because of what? Because of
That's
what?
because of the high elasticity of the host dissemin.
What is the relation between the high elasticity of host dissemin and to choose the DMEK graft or the ZEG graft? Anyhow, for my own experience, I don't know if you some of you know or not, I have never did a single case of the ZEG. My experience only in DMEK, so I have never used to do the ZEG at all. But I think DMEK is much better, especially you are dealing with a young age. They are dealing with a young age, for example, 7 years, 8 years. So as you know, also the ejection rate of DMEK is about 11 times less than the ZEC. So when so I advise making DMEK, not the ZEC in Shed syndrome. And the same also question may come here as regard, do you usually do dysmatorexis in Shed or no? Because as you know, descemet membrane is very, very adherent in young children. So some also advise putting the new DMEK graft over the patient's endothelium. But others do advise making dysmatorexis. For myself, if the patient is young, 3-4 years, I will put my DMEK graft over the patient endothelium. But if the patient is 8, 11, 12 years, I can do dysmatorexis in age. So the question is, should be about do you do dysmatorexis or not in such cases? I'm sorry, I have laryngitis.
What about
I'm having laryngitis and
no,
my
your voice is
is
clear, I think.
okay, great.
سلامتك ان شاء الله دكتور طارق، سلامتك.
الله يسلمك، الله يسلمك.
الظاهر بتغني كثير.
يظهر كده بغني في
Do you
السنجاب
usually do
تفضل دكتور براء. I'm happy with the interaction.
a cataract in a patient who has a normal lens and you want?
Excuse me, Dr. Bara, I am very happy with this interaction from the audience. I am very happy with the quality of questions which have been asked. I'm ready to hear more. So what is the last, what is the question, Dr. Bara?
Yeah. Do you prefer routinely to do a cataract surgery before doing the DMEK graft if someone has a normal lens?
You speak about the combination of Fuchs dystrophy, management of Fuchs dystrophy, because if you have a case of pseudophakic, the patient already is pseudophakic. But if you have a Fuchs dystrophy, it depends upon the age of the patient. If you have Fuchs dystrophy in a patient under 40 years, you do DMEK only. But if you have a patient who is over 40 years, you should remove the lens, because as you know, the injecting an air bubble in the anterior chamber, this cataractogenic. So you will be having cataract after a few months. So it is easier to remove it early. But if you have a patient, for example, 30 years, 35 years, still young, you can preserve his lens. So it depends upon the age. If it is about below 45 years of age or 50 maximum, do DMEK alone. If you have a patient above 45 or 50 years, do triple phaco DMEK, which is a also very nice operation.
Is there any risk if we enter the eye after a few years maybe of DMEK that the graft detaches during the surgery or
no? I don't think there is any fear to it. It's completely adherent. I think the fear is from the endothelial cell count. With many years, you may have loss of endothelial cell count. And if you are doing any maneuver, if you don't have a borderline endothelial cell count, you may have graft failure. But I don't think that the graft has any instance of detachment. It's completely attached after one few weeks, completely attached.
Great. I think that's all for now, Dr. Tariq, and we exceeded the limit. Wonderful lecture as usual, and I'd like to thank Dr. Mazen again for this opportunity to have you. And I would encourage anyone who is interested in this topic to go back to the last lecture on the Sinjab Academy that you talked in details about the DMEK surgery, not only orientation and unfolding. Thank you again. And Dr. Sinjab, if you want to finalize the session.
Yeah, thank you very much, Dr. Tariq. I think there is a question just posted by Amir Dalloul. When would you do rebubbling if you have detachment, Dr. Tariq?
This is a very great question, the timing of rebubbling. Of course, we do rebubbling if you have more than 30% of the graft is detached, or if you have part of the center of the graft is detached. The timing is, I usually talk to the patient before the operation. I tell them that we will leave you your eye full of air, and the final decision as regards success will be after 4 days of the operation. So after 4 days, we'll be having two situations. About 90%, you will be having graft attached, and in about 10% or maybe less, you will be having part of your graft is attached, and you will need another rebubbling. So the perfect timing for decision is about few days after the operation. Everything will be clear. But if you have a very small detachment in the periphery and the center is attached and everything is okay, you can leave this small detachment for observation. But if you have a large detachment, more than 30% or central detachment, and you have to go directly to fix it again.
Okay, thank you very much. Dr. Bara, did you take the question of if the cornea is hazy enough to do the phaco surgery? Did you take it?
No.
No. Okay,
I
there is
think
a question.
I asked him a similar question, yeah. But
What is
he's
the
asking
question?
if the cornea is so hazy that you, what if the cornea is hazy enough to do the phaco surgery? Which surgery would you should do first, phaco or DMEK?
If the cornea is hazy, not, but for this question depend upon the haziness of the cornea, and it's a very important question. You should do, of course, we would do phaco before doing DMEK. I can't do DMEK and then do phaco. We do phaco first if we are doing combining the operation. So I will do phaco first. So to improve visualization, I have to do some steps. First of all, removal of the epithelium gives me a perfect view. So this one issue. Second item, when you remove the descemet membrane, also it improves visualization. So, and thirdly, if you are doing phaco, you have to keep in mind that the main concern in your phaco is to keep the capsule intact. You can make, for example, rough manipulation with phaco because you will not be afraid about the cornea. So you have to make a proper decision. If the amount of haziness can be improved by first removing the epithelium, second removing descemet membrane, thirdly you are confident in your technique, you can work through a slightly hazy cornea, and sometimes you may improve your technique also by using the endo illumination from the outside. So if you can overcome all this haziness, so you can go for phaco and doing DMEK. But if you have the view is hazy, very hazy, so you can do the DMEK first and then wait for a few months and then you can do FECO later on. But this is somewhat a theoretical question. In my experience, the combination of Fuchs and cataract, usually Fuchs doesn't jeopardize the visualization during the phacoemulsification, except if you have some scarring. And if you have some scarring, this will not be suitable for DMEK. So if you have the haziness and you cannot see for sure doing the phaco, you can do DMEK only and wait for the phaco. But if you have the scarring, not haziness, I think you should change your policy and instead doing triple extracapsular and penetrating keratoplasty.
That's the question. Can you do rebubbling on the slit lamp as some doctors do?
For myself, at least in my own hands, I don't believe in doing any maneuver in the slit lamp because of the sterility problem, and the patients are not so cooperative, and I want to make a controlled injection of air bubble in the anterior chamber. I want to adjust the size of it. So I don't think that doing this on the slit lamp is a good decision. I don't believe in such maneuvers on a slit lamp. This is my own experience. I have tried, of course, but I find even I sometimes after injecting air in the anterior chamber, I let the patient to be in the ward for a few hours to check his bubble. Sometimes I find the bubble is large, so I want to just slightly decrease the size. I don't even do this on the slit lamp because if you touch the paracentesis to decrease the bubble size, it's not controllable. You may find that the whole bubble escapes suddenly, and you want to re-inject air again, and just you are not in the proper sterilization situation, and the patient is not so cooperative. So I don't think, at least in my experience, I don't advise anyone to do these minor techniques on the slit lamp.
Dr. Tariq, there is a continuation of the previous question. When the cornea is hazy and you want to go for phaco, have you used in those cases the endo illuminator or chandelier light to get better visualization for the phaco?
I have mentioned this in my my last my reply. I have mentioned it,
okay.
but for myself, I don't have an experience in doing
okay.
phaco. But I have mentioned this is one of the ways to improve your visualization.
Okay, thank you. Okay, great. So we came to the end of this interesting session. Thank you very much, Professor Tariq, for enriching our knowledge and for sharing your experience. Thanks to Dr. Bara as well for moderating the session. And thanks for the audience for being with us. And of course, the presentation is being recorded and I'm going to upload it to Sinjab Academy. You can find it in Sinjab Academy in the Cornea series. Thank you very much and have a good night for everybody.
And I want to just, before you close the session, I want to thank you as well, Dr. Sinjab, for your great effort and for the opportunity you have given to me to reach to all this great audience all over the Arab world area. And I hope that my lecture will help a lot of surgeons to start doing the DMEK, because the aim of these sessions is not just for giving lecture. The aim is to this technique I wanted to spread all over the whole area, because I highly believe in this beautiful operation.
Thank you, Dr. Tariq. Actually, the audience, not only from the Arab area, we have audience from Latin America, from Europe, from India. I know some of them by their names. They are here in the list. So as you see, you are international. Thank you very much.
Thank you very much. Thank you.
Okay, goodbye, everybody.
Bye. Thank you.